hyperopes. So they have a hyperopic refractive error, and once you correct that, if the accommodation is normal, that is normo-accommodative. What is AC by A ratio? I would like to briefly tell here. So when the eyes see anything for near, that is accommodation, there's also a simultaneous convergence that is happening because of the innervation to the medial recti. So for every 1 diopter of accommodation, around 3 to 5 prism diopters of convergence is happening. So that is normal. But if it goes beyond that, that means the accommodative convergence is more than per diopter of accommodation. So if you've given a refractive correction and the child still has a deviation, that means there is something abnormal with the convergence that is happening. So high accommodative convergence by accommodation ratio. You also have non-refractive accommodative squints wherein you have no refractive error, but there is some problem with the accommodation. And that is why when the child is focusing on near, because the accommodation is poor, you have to exert higher accommodation, and that is why a higher convergence. Okay. So a weaker accommodation may have a normal AC by A ratio. However, the child will not be able to have a near point of accommodation or a near point of convergence as per his colleagues. The near point would have receded, something like what you see in presbyomes. Okay. And you have hyper accommodative. And when you have an element of accommodative along with an infantile component, you call these patients as partially accommodative. So if a child walks into your OPD with an inward deviation of eye, what are the certain things that you need to take care of? Okay, this is more of a practical based approach. So you will firstly see whether it is a true esotropia or is it a pseudo esotropia. Sometimes you have these epicanthic folds, okay, which can mimic a pseudo esotropia. So if we pinch the skin or do an alternate cover test, you will not have any manifest deviation. Flat nasal bridge or small IPDs can also reveal as a pseudo esotropia. Once you've ascertained that the esotropia is true, you see whether it is latent or intermittent, happening at some times, or variable on distance or near, or changing in its amount of deviation at different points in time, or is it a constant esotropia? Coming to the history part, you'll ask the child about the parents about the onset of deviation. So if the onset of deviation is less than 6 months, it is generally which one? Infantile. Very, very rarely you can have some accommodative squints also developing at 4 to 6 months, but mostly infantile. Between 2 to 3 years or 18 months to 3 years, we generally get an accommodative component. Can you tell me among infantile and accommodative, which will be larger deviation? Infantiles are generally larger deviations, whereas accommodatives are generally smaller deviations. And if a child gives history of any surgery for outward deviation and now has inward deviation, then it is a consecutive esotropia. You proceed on to measure the amount of deviation, the most basic test being Hirschberg's corneal reflex test, and you do a prism bar test to measure the deviations. But young children can be uncooperative for examinations, so Prinsky's might help you ascertain how much is the deviation. So in Prinsky's, you're basically putting a prism on the deviating eye, on the eye, and then you're seeing the corneal reflex on the other eye. Okay, when it becomes central, you say, okay, this much is the amount of deviation. Infantiles are usually associated with larger abdominal deviations, whereas accommodators with a smaller deviation. And these deviations can change with time due to secondary changes in the medial rectus. Next important thing, after measuring the deviation, you need to see the extraocular motility. Okay, is the motility full and free in all directions of gazes, or is there a limitation? Is it paralytic? Is it restrictive? In most of the infantile ESOs, when you see as if there is a partial abduction deficit, abduction deficit in both the eyes. You have to rule out the sixth nerve palsy. How can you do that? You try to rotate the child's head. That's called the doll's eye maneuver. And this abduction deficit is basically because of the cross fixation that is seen in these children. Okay. So when you're seeing the right-sided field, the child's left eye will be seeing the right-sided field. Okay. And the child's right eye will be seeing the left-sided field. So this eye will go inwards to see here, and this eye will not move outwards. So it appears as if there's a abduction deficit. So you can do a doll's eye maneuver, or you can patch the eye. So this eye, which was initially ESO, will come central. Associated findings have to be seen, which are mostly a feature of the infantile esotropia syndrome, that is your cross fixations or dissociated vertical deviations, inferior oblique overactions, which generally come in after 1 to 2 years of age, and any presence of latent nystagmus. In cases of paralytic or squints, you can also have a abnormal head posture. The most important test for any child with a deviation is refraction. So you have to do a refraction under atropine for all these children. Okay, especially in cases of esotropia in younger age, it has to be done under atropine to see the total amount of hyperopia and to relax the accommodation. A full cycloplegic correction has to be given. So even if the child is less than 6 months of age and you're suspecting infantile, even then the refraction has to be done and seen for any refractive errors. Mostly they have refractive errors of 1 to 2 diopters, which are usually age related. And full-time use of spectacles has to be given and compliance has to be ensured. In accommodative, these are usually moderate to high hyperopes, around 2 to 6 diopters. And when the spectacle is given and still the child has some amount of esotropia, you have to see either it is a partially accommodative or is there a abnormal AC by A ratio. Okay. If there is more convergence than accommodation, you need to relax that convergence by supplementing that accommodation, basically giving bifocals. Okay. And when you give bifocals in these children, you have to ensure that it is not the bifocals you give for adults, the cryptop. It is an executive bifocal. It has to be a large frame so that it covers the whole eye, snugly fit, and the executive line has to pass through the pupil or the lower border of the pupil. You will always assess the visual acuity. You have to assess for any amblyopia. So when a child comes to you, the alternate fixation is there, you suspect the vision is equal in both the eyes. But if a child has a constant squint, predominantly in one eye or a dominance, then it is likely that the other eye is amblyopic. So amblyopia therapy is one very important therapy to be given for all children before surgery or during treatment and to be continued after intervention. Binocular single vision testing for suppression or any ARC has to be checked. You have to rule out any sensory causes of squint and rule out any fundus pathologies before proceeding on to your further management. Briefly talking about the management, it can be non-surgical, primarily by spectacles. These are high hyperopic spectacles given mostly in cases of accommodative esotropias. Amblyopia treatment, which goes hand in hand with any type of management. Orthoptic exercises, especially when you have non-refractive accommodative. Okay, when you have a weaker accommodation, that is when you want the divergence, you want to stimulate the divergence amplitudes. So orthoptic exercises and then surgery, which is the mainstay of treatment for infantile. So in spectacles, you have to give a full hyperopic correction. Okay, you do not subtract for the cycloplegic. You give a full hyperopic correction. You relax the accommodation. Sometimes the children do not tolerate these glasses well. So you can start these glasses under the effect of atropine. If it is still not tolerated, you can always start with a lower power and then gradually increase or use fogging. You assess the deviation after 4 to 6 weeks of the spectacle use. And it is very important that the refractive status has to be checked every 3 monthly in a child less than 1 year of age and every 6 monthly up to first 5 years. In cases of less than 6 months, if there's a refractive error, because the field of the eye field of the child is basically near, you give a plus 1.5 diopter near eye. You do not give bifocals, you give 1.5 diopter near eye as a single vision spectacle. In cases of high AC by A ratio, more than 5 diopters, prism diopters by diopters, you give bifocals like we discussed. And this has to be repeated. And you always check if there is any consecutive exotropia happening. In those cases, you might need to decrease the power. Amblyopia therapy is a must to maintain the alignment whether with glasses or pre and post surgery and has to be suspected if there's a unilateral or a constant esotropia with dominance in one eye. Orthoptics are important. It has a role for amblyopia management as well as to increase the fusional divergence reserve. And surgery is the mainstay of treatment in infantile esotropia. Surgery can be done as early as 6 months, but should be done between 6 months to 2 years so that you have some amount of peripheral fusion present in these children to maintain binocularity. If a child is infantile with equal vision in both the eyes, you can go in for a bimedial recession. Okay, both the eyes, medial rectus can be recessed. In case there is a preference of one eye and one eye is into constant ESO, you can go in for a recess-resect procedure in that eye. Whenever you're suspecting amblyopia, you can go in for a recess-resect. Medial rectus is recessed and lateral rectus is resected. In cases of partially accommodative, you will always give the spectacles first, then check what is the residual amount of deviation. And only that residual deviation has to be corrected by surgery, not the complete deviation. And if you have associated features like DVD and eye overactions, that can be taken care of. Eye overactions can have inferior oblique weakening procedures. If it is a DVD with eye overaction, again inferior oblique weakening procedures. Only DVD without eye overaction can undergo superior rectus recession procedure. So can you tell me what does this picture tell you? What are you suspecting? This is a 5-month-old child. This is an infantile esotropia. What features are going in favor of this child? Large deviation. Okay, there may be some amount of cross fixation. What are the other associated features you will look for in this child? Yes, DVDs, eye overactions, abduction. Any other feature that you're seeing here in this child, in these two children? You have inferior oblique overactions. If you can appreciate here, okay, you have inferior oblique overactions associated with the infantile esotropia. Can you tell me what does this picture tell you? What kind of squint? Accommodative. So these are three different children. You see there's a deviation in the eyes, esodiviation, and refractive correction has been prescribed, and the children appear to be ortho now. Okay, so the glasses have to be continued. After 4 to 5 years of age, we can try to decrease the power of the glasses once the accommodation has been relaxed and observed. What is this kind of a squint? Yes? What is this kind of a squint? First of all, he's wearing glasses. So it is a refractive, okay? Accommodative, because it is now corrected after glasses. Refractive accommodative. This is also refractive accommodative. How is this one different? Yeah, how is this one different? He's using executive bifocals. Okay, you can see the sole line. The placement is not correct. It should have been snugly fit and bisecting the pupil. But this indicates what? High AC by A ratio. How do you measure this AC by A ratio? Anybody? How will you measure? We're all talking about AC by A ratio. So basically we said at near, whatever accommodation is happening, the convergence is in excess of that. So after giving full refractive correction, you will measure the deviation at near. Not with the torchlight, but the child has to focus on some object. We'll measure how much is the deviation after wearing glasses. Then you will relax that accommodation. How will you relax? By making the child wear +3 diopter glasses. So the accommodation is relaxed. So ideally the convergence should also be relaxed. So you will measure how much is the residual deviation now. Okay, so the difference in the deviation only with glasses and then glasses with +3 diopters at near, the difference divided by how much power you are using, 3. Okay, that gives you the AC by A ratio. This is the gradient method. You have different methods to see the AC by A ratio. So this is a child with high AC by A ratio, which you neutralize with the bifocals. So this was a girl who had 60 PDs of esotropia and underwent a triple muscle surgery. So bilateral medial rectus recession, but because it was large, we did undertake a lateral rectus resection of one eye and post-op is ortho. So when you have consecutive esotropias after surgery, what procedures can be done? So you will have to see what was the procedure done initially. If a bilateral medial rectus recession was done, a bilateral lateral rectus recession was done for exo, and now the patient has gone into exo, you can go in for bimedial recessions. If one eye recess resect was done previously, you can go in for the other eye recess resect now, or you can advance the recessed LRs. Exotropia, the LR was recessed initially. You can advance it to the original insertion and resect the medial rectus. In cases of paralytic squints, you can also go in for a botulinum toxin transiently to prevent contracture of the medial rectus while you are waiting 6 months for the recovery. So can you tell me what does this case show to you? This is an esotropia. The primary, basically this patient had actually an exo. There was a corneal opacity here. But this left eye was a fixing eye which appears inwards now. The right gaze is full and free. What do you see in the left gaze? There's restriction of abduction. So what is this case? Left LR palsy. And what does this picture show to you? Significant abnormal head posture. The patient did not have diplopia because he had mild diplopia, which surprisingly, despite this corneal opacity, and he was only 1 meter vision in this eye, but he did complain of diplopia. He had a significant AHB. So we took a Botox injection in the left eye MR, and the patient was doing well at 6 months follow-up. You can see there is recovery of the abduction. This Botox has not led to recovery of the abduction. It has only prevented the contracture. The recovery is spontaneous. What do you see in this child? See the gazes, left gaze, right gaze. There is some amount of DRS, okay. So whenever you're seeing the extraocular motility, you will always check for the aperture changes also. And this was actually not a case of DRS, although the pictures do seem like that. That was acute LR palsy that this patient came in with diplopia. She was a 25-year-old female. And we did give a Botox, and after 6 months also there was residual lesion. So we undertook her for recess resect procedure. So the take-home message for a patient to be worked up for a case of inward deviation is the first must is a refraction under atropinization, a full hyperopic correction in all cases of esotropia, and then followed up every 2 to 3 monthly in the first year and then 6 monthly refraction. Amblyopia therapy. Just surgery will not cure these patients. Amblyopia therapy has to be undertaken, started pre-surgery, continued post-op, and continuous monitoring and follow-up has to be done. Early surgery in cases of infantile squints to promote stereopsis, and all treatment modalities should go hand in hand for better long-term outcomes. Thank you.
Thank you, Dr. Anu, for excellent talk. Any questions to Dr. Anu?
Very interesting and nice presentation. Anu, you try to cover everything in a very short time, but I think two things I want to stress. One is that infantile deviations are a different cup of tea, because if you don't look after them early, because binocularity is developing. If the deviation is there, the binocularity will not develop. So it is very important to catch them differently and interfere early. So you can do surgery by about 8 months to 2 years is the upper limit. It should be 8 months to 1 year, 1.5 years. So that is the time, because there will be some opportunity for having some binocularity. Because if you do surgery later than that, they will have very poor binocularity. So that's very important point about accommodative one. She has talked very nicely. Only thing we have to see that for non-refractive accommodative, that is high ACY ratio, one need not be a hypermetrope. You can be a hypermetrope, one can be emetrope, and even a myope. So we're seeing a lot of strabismus, which is I think increasing because of rising incidence of myopia. We're seeing more and more of strabismus, be it ESO, be it EXO. So that is also happening. So these few things are important. You probably couldn't cover acute acquired and sensory esotropia. So they are also important, because some sensories probably they go for EXO also later on. So anything anybody would like to ask or say something? Then should we move to the next topic?
Thank you, Dr. Anu. Now I invite Dr. Ishita Bazar. She will be speaking on exotropia.
And one thing more, sorry, about infantile deviations, they can often have a dissociated horizontal deviation. So if you have not looked for it, they will go for consecutive EXO. So it is important to look at dissociated horizontal component, which is usually EXO deviation, and to take that into account. So if that be so, you do less surgery in these cases. Same thing about partially accommodative esotropias. The amount of surgery has to be, they tend to be undercorrected. It's a known phenomenon. So you have to plan for slightly more surgery in partially accommodative ones.
So I have one question.
Without
So suppose there's a long-standing squint, do you recommend always a surgery should assist amblyopia therapy, or you recommend occlusion prior to taking up these children for surgery in esotropia?
There is no unanimity on that. Actually, it will depend upon the situation also. In our country, some children are coming from rural background. It's not easy for them to come for repeated follow-up and visits. So in those situations, of course, if the amblyopia part has been taken care of, then the chances of better alignment are there. But if that cannot be, then maybe you can do surgery and amblyopia therapy can follow. So there are no very clear-cut guidelines on that. Depends on the situation.
Our article is there in EPTA 201. You can go through that.
I think the fixation status also has to be taken into consideration. How is the fixation status? If it is central, then you can, and the age is like that, amblyopia therapy is not going to help much, then you can go for surgery and then, like Sir said, continue with amblyopia therapy. But if you're dealing with a central fixation or it is not fixing very well, then amblyopia therapy should be started, because otherwise the chances of overcorrection are very high.
Amblyopia therapy should be started,
Yeah.
but surgery can be done if there are issues. I think so. It doesn't stop not operating. Okay, please go ahead.
Good morning, everyone. I am here to discuss my topic, the outward challenge, exploring exotropias. I am Dr. Ishita Bajaj, working in Guru Nanak Eye Center. So, intermittent divergent squint. So, exodeviations most commonly present as phorias or intermittent exodeviations, which latter spontaneous, the latter, which is the intermittent exotropia, spontaneously breaks into manifest deviation. And this comprises of about 50 to 90% cases of all cases of exotropias, and it's usually preceded by a stage of exophoria. Symptoms, mostly the patients are asymptomatic. They can have transient diplopia. Esthenopic symptoms usually develop when the fusion begins to succumb. The most common and the most important feature of exodeviation is diplophotophobia. So basically, when the patient goes out in bright sunlight, it dazzles on the retina and breaks fusion, which leads to sudden diplopia and confusion, for which the patient has to close one eye. So this is known as diplophotophobia, which is very characteristic of exodeviations. Then the natural history, there are 4 phases of exodeviations. It starts with the exophoria at distance, where the patient is nearly asymptomatic. And then there is intermittent exotropia for distance and an ortho or exophoria for near. Here the patient has symptoms only for distance. Then an exotropia, a manifest exotropia for distance, and a phoria or intermittent exotropia for near, where the binocular vision is still maintained for near, but there starts to develop a suppression scotoma for distance. And the last stage is exotropia, which is present for near as well as distance, where the patient now lacks binocularity. Classification of exodeviations, it starts with exophoria, then we have comitant exotropias, which can be primary or secondary. Comitant means it's equal in all cases. Incomitant exotropias can be because of oculomotor palsy or isolated MR palsy. It can be restrictive, like in case of Duane's distraction syndrome. Mostly type 2 and type 3, and then there could be dissociated horizontal deviations. History, it's important to know the age of onset of deviation and whether the deviation is constant or intermittent, static or progressive. History is very important because trauma or a previous surgery can lead to a break in fusion and then exotropia thereafter. History of use of glasses, occlusion therapy is important in taking history of all squint patients. History of febrile episode is very important because this usually leads to a break in fusion, and this is a possible cause for decompensation. Birth history, prematurity, ROP, instrument delivery is very important. Family history, examination. So we start with an abnormal head posture. Head posture can be a head tilt, it can be a face turn, chin elevation or depression. Then the visual acuity assessment is very important, and the refractive errors should be assessed and fully corrected before progressing to anything else. Then comes the deviation measurement, Hirschberg's test, measurement of maximum deviation. We usually, for exotropias, we usually patch the patient. So earlier the theory was to patch it overnight or for 24 hours, but now they say that a 30 to 40 minute monoocular occlusion also suffice. Distance near disparity should be checked at 33 centimeters and 6 meters, and any AV pattern or oblique overaction should be assessed. Then progression of ITS, there are some factors to be recorded for progression. For example, loss of fusional control, development of a secondary convergence insufficiency, increase in the basic size of deviation, and development of suppression. These are also indications, if these are progressing, these are also indications for surgery in a case of ITS. Then there are etiology of ITS, there are theories which are given for the development of ITS. So this includes Duane's innovational theory, then we have a mechanical theory. This I think can be covered in theory. Then patients with ITS, they usually develop sensory adaptations. In phoric phase, where there's only a phoria, a bifoveal fusion is present with excellent stereo acuity. But in a tropic phase, there is a large temporal retinal suppression. ARC also develops in the tropic phase. Then monofixation syndrome, which is less common in exotropias and more common in ESO. And amblyopia rarely develops because it's mostly intermittent and the patient has alternate suppression. Characteristics: age of onset is important. There's female preponderance. Precipitating factors of tropic phase, like children when they are sick, tired. So the parents usually come and tell them when the patient is sick or tired or lost, like daydreaming, then the parents usually see a tropic phase. Adults, sedative intake or alcohol consumption can lead to this. Then we have a case of a 9-year-old boy who had IDS but a very poor control, and he was 6'6" both eyes. And also to note that the most common refractive error associated with IDS is astigmatism. He was 6'6", best corrected vision, and he was operated. He was 40 PD for both near and distance. There was no near distance disparity. A 5 and 8 MR resection, LR resection was done, and the patient was ortho. So here the indication of surgery was because he had a poor control. Then this was also a decompensated IDS, 11-year-old female, 6'6" both eyes, hardly any significant refractive error. 40 PD again for both near and distance, and again a 5 and 8 MR resection and LR resection was done. Here, this is the third case of decompensated IDS, adult female. Here to notice that the V pattern which is present is not because of oblique overaction, and there was a left strabismic amblyopia. So in these previous cases, because it was an alternating IDS, we have done a unilateral surgery, but we could have also gone ahead with a bilateral lateral rectus recession. But then usually in cases of amblyopia, we prefer to operate the amblyopic eye, and because here the V pattern is not because of oblique overaction, we could have just transposed the MR and LR. And also a trial of occlusion therapy should be given for all cases of amblyopia before proceeding for surgery. This is a case of decompensated IDS with both eyes grade 1 inferior oblique overaction with right anisometropic amblyopia. His astigmatism was -6 in the right eye and hardly any in the left eye. He was also given a trial of occlusion therapy and followed by a right eye 6 mm MR resection and LR resection. So here we operated the right eye because it's the amblyopic eye, and grade 1 inferior oblique usually not has to be operated, or it can be in cases if it makes a V pattern. This is also a case of IDS with right anisometropic amblyopia with V pattern. So here we did a half muscle with LR upshift and MR downshift along with 9 mm LR recession and 6 mm MR resection. This was post-op day 1. So there was no V pattern present. You can see a V pattern in the pre-op picture, and there's no V pattern in the post-op. Then this was decompensated IDS. Here there was grade 2 inferior oblique overaction. So IO recession can be done. This is post-op. Then there are classifications of IDS. This is the basic classification. So we have 4 types. This is the Berlin classification. The basic type is the one where the distance deviation is within 10 PD of the near deviation. Divergence excess is where distance deviation is 10 PD more than near deviation, and this is even after the patch test. So this is true divergence excess. Convergence insufficiency is near deviation is 10 PD greater than the distance, and simulated or pseudo divergence excess is for larger exotropias for distance than near, but when we do a patch test, the near and distance become equal. So this is a simulated divergence excess and not a true divergence excess. Then we have a Kushner classification. Most important to see here is the tenacious proximal fusion, which is responsible for the intermittency in divergence squints, and is the most common type of IDS which is present, the exotropia. Then subjectively to assess the control, there are two. So there's a home control and there's office control, which can be seen here. Objective assessment can be done on the basis of distance and near stereo acuity. Then this is very important. Newcastle control score is there. It's a score total out of 7. This incorporates a home control where the parents have to notice the child, and then there's clinic control, which is near and distance both. So it's a total of 7, and a total of 4 or more indicates surgery. Then moving on to the second type of exotropia, it's the infantile exotropia. It's relatively rare. And before making a diagnosis of infantile exotropia, it's important to rule out any sensory deprivation or a neurological disorder in the child. It usually develops before 6 months of age and it's constant, usually constant. It's a classification of infantile exotropias. This can again be primary and secondary. So this was a case of a 22 months girl, both eyes following light, a -1 diopter of refractive error. She was around 55 PD. So a FDT was done to see for any restriction, and the surgery was performed thereafter. This was after ruling out any neurological or sensory deprivation. This is a case of 10-year-old girl, infantile exotropia with grade 1 inferior oblique overaction with strabismic amblyopia. Occlusion therapy followed by surgery was the plan. This also is V pattern, infantile exotropia without any oblique overactions. So here also 6 mm MR resection with 9 mm LR recession with transposition was done. Then etiology, it can be neurophysiological and neuroanatomical theories have been given for infantile exotropias. Clinical features, it usually develops before 6 months of age. It's usually large angle, more than 30 PD mostly, and the near and distance deviation is mostly equal. It can be associated with DVD or inferior oblique overaction like infantile exotropias. Then sensory exotropia is the outward drift of the eye in a blind or poorly seeing eye. So the very young children and children usually more than the age of 7, they develop exotropias. And it has been found that patients with congenital vision loss are significantly more likely to develop esotropias, and those with acquired vision loss, they develop exotropias. Then consecutive exotropia is a manifest exotropia that develops after optical or surgical treatment in a patient that had previously esotropias. And probable risk factors, they include amblyopia, preoperative amblyopia, a high hyperopia, presence of A or V pattern, DVD, or a post-op limitation in adduction. Small angle exotropias are defined as less than 20 PD, and they can be, so these are the only category of exotropias which can be managed conservatively. They can be observed, they can be orthoptic exercises, over-minus lenses which stimulate your accommodation can be given. Surgical management is done only when the patient is persistently symptomatic or it progresses. Then a brief about management of IDS. Controversies. Measurement of deviation. A distance deviation measurement is very important, and for near, the accommodative target is set at 33 centimeters and the near and distance deviation is measured. Why? Because control of distance deviation is compromised first. Full deviation may not be apparent at lesser distances, and exo deviations may increase beyond 6 meters. Duration of patching, so it was found out that a patching of 30 to 40 minutes also suffice for measuring the maximum amount of deviation. Orthoptics and surgery are the two options, and we have to balance between the two. Indications of conservative management, as we discussed, small deviations, excellent control, and very young children. First step is obviously correcting the refractive error. We can, in small angle deviations, we can also give over-minus glasses because they stimulate your accommodative convergence. Then prisms can be tried, part-time occlusion, botulinum toxins are all. Anti-suppression exercises can be done. Role of orthoptics, it is to supplement your exodeviations and not a substitute. Indications for surgery, large angle deviations, deteriorating fusional control, increasing size, frequency and duration of tropic phase, deviation present more than 50% of the waking hours. This the parent has to observe at home. And failure of conservative therapy, development of suppression and loss of distance acuity. So according to the Newcastle score, well control is a score of around 2 or less, which only requires vision therapy. Then 3 to 6, it's better to go with the surgical management, and more than 7, obviously surgical management. Surgical considerations, timing, type, and goal of surgery. The goal of surgery is alignment within 10 PD of orthophoria. Age of surgery, early surgery as advocated by NAP, it prevents your sensory changes, it reduces risk of conversion to constant squint. It also, but there is a risk of monofixation in cases of overcorrection. So a slight esotropia in a child can cause monofixation and a dense amblyopia. Also, the child is more likely uncooperative, so the measurements are a problem. Delayed surgery, as advocated by Jampolsky, it's more accurate diagnosis, more precise measurements. The progress of exotropia can be observed, and overcorrection has little risk of amblyopia. Then, choice of surgery. Divergence excess type should be preferably treated by bilateral lateral rectus recession. Convergence insufficiency by a bimedial resection. A basic or a simulated divergence excess can be bilateral recession or a unilateral LR-MR. Goal of surgery is to restore the alignment and preserve your binocular function. Surgical procedures, just a brief, weakening procedures, recession and Fardin's procedure, marginal myectomy or myectomy for small deviations, and strengthening most commonly is resection, and plication can also be done. So this is just a difference between plication and resection. Resection is obviously irreversible, but the results are more predictable versus plication, which is reversible. It has less surgical trauma. Surgical time is less and less chances of slipped or lost muscle. Then unilateral or bilateral surgery, your surgery should always be symmetrical if the squint is alternating. But if it's an amblyopic eye or a fixation preference is present, we can also go with unilateral surgeries. IDS with lateral incompetence, where the lateral gaze deviation is more than in primary gaze. So these patients are more likely to be overcorrected after surgery. So we have to take into consideration that part, and we have to do a lesser amount of recession. Complications can be overcorrection, which can be managed by part-time occlusion or prism. Resurgery, if there is more than 20 PD, and even after 6 to 8 weeks of surgery, if it persists, we have to go for a resurgery. Under corrections, less than 15 PD, usually non-surgical measures are taken up, but for more than 15 PD, we have to do a resurgery. Prism adaptation test, it is basically described for acquired esotropias, but this can also be done here, and it can help in reducing long-term over or undercorrections. Refractive errors, undercorrected myopia, less than normal accommodative effort is required during near vision. This leads to a decreased accommodative convergence, and understimulation of convergence may cause an exodeviation. Astigmatism and anisometropia should always be corrected, and it's the most common refractive error associated with exodeviations. In patients with very high uncorrected hyperopes, no effort is made to converge. So these patients may also have exodeviations, in contrast to a mild hyperopia, which usually have esodeviations. This is management of pattern strabismus. This depends if there is oblique overaction or not. If there is overaction present, we usually go ahead with inferior oblique recession. Otherwise, we do a MR and LR, upshift and downshift. Thank you so much.
Thank you, Dr. Ishita, for excellent talk. Any questions to her?
Also to note that the HBT is central in his eyes. So this is a pseudo strabismus and not true strabismus.
Any questions to her?
Can I say so?
Yes.
I think very nice presentation. The only thing is that there is a very narrow dividing line between phoria, tropia, infantile, and IHT. So one has to have some, like you can have IDS at the age of 4 months also, for example. And the problem with infantile exos is that as compared to infantile ESOs, where they don't fuse because the eye is in ESO derivation. In exos, what is happening, they still have some fusion. So that fusional ability is there, so intermittently they are also fusing. So that overlap takes place. So at times it becomes very difficult to say that it is infantile or it is IDS. Other thing is in infantile ESO, you have lot more of DVD, lot more of LM as compared to infantile exodeviations. About surgery, you said these days we tend to prefer bilateral LR recessions in most of the situations and less of R&R. That trend is there. Even in convergence insufficiency, there are reports that you can do slanted LR recession. The other MR resection would have their own issues. So it's a very broad topic. We are seeing a lot more exotropias now. When we were younger, we were seeing more ESO and less EXO. Now I think we have moved towards more EXO and less ESO. The reasons could be many. One could be that we are correcting, probably children are being corrected for their accommodative part, the refractive error is being corrected. So that could be one, and then of course increasing myopia, which is adding to more and more exotropia. And of course, one thing you rightly said, I've also seen, it is a lot of astigmatism. If it is there, it is a very important consideration in exodeviations. If you look at literature, they would say refractive errors are almost the same, but probably it's not true. This needs to be evaluated. I think we see a lot of, in almost all cases, will have some astigmatism. That is a very important point. So whenever fusion is breaking, you will have an exodeviation. Thank you. Anything?
So I just like to add a point. So the case of intermittent exotropia, they are very, very common nowadays, and lot of patients are coming with myopia. So now I think as the incidence of myopia is increasing, since myopia is usually associated with accommodative lag, so the incidence of intermittent exotropia is also increasing. So this has to be taken care, and these are the patients who are presenting very young. They're presenting even like Sir said, they're presenting in the first year of life also. And if you see, either these children are pre-myopic or they are towards myopia. And some of them even present with the high myopia with intermittent exotropia. So these children have to be taken care for frequent close follow-ups have to be done. You have to give them refractive correction. And I have seen there is a very good role of maintaining their fusion potential. If we can work on that, these intermittent exotropia can be controlled. So we should not jump to surgery in such patients, because later on you might have overcorrections and you can get a consecutive beat.
In younger children, they need less amount of surgery for the same. That's an important thing, because if you do same amount of surgery in children, especially children who are about less than 4 years, they will end up with overcorrection. So that precaution has to be done.
Thank you, Dr. Ishita. Now I invite Dr. Bhavna Krana. She will be speaking on superior oblique palsy, the science, diagnosis, and management. Dr. Bhavna.
Bhavna has been our ex-student, and she's very hardworking, sincere person, and a lot of interest in Strabismus, and she's doing very good work in Strabismus. Dr. Bhavna, please.
See, it feels very good to be great to be back to GNEC for this presentation, and sincere gratitude to my teachers, Dr. P.K. Pandya sir and Dr. Subhash Pandya sir. Their invaluable teachings have really helped me to lay a very strong foundation in Strabismus. So I'll be talking on superior oblique palsy, the science, diagnosis, and management. So brief applied anatomy of superior oblique palsy. So the three primary actions are intorsion, that is it rotates the eye inward, depression, and abduction. So a case of superior oblique palsy will have extorsion, that is the eye becomes rotated outwards. There's a loss of depression, and loss of this function causes the eye to drift upward, known as hypertropia, and a loss of abduction. So brief applied anatomy of the trochlear nerve. So the neuroanatomical vulnerability of trochlear nerve in the form of a long intracranial course. As we know, it is the longest and thinnest cranial nerve, making it highly susceptible to damage. It's the only cranial nerve to exit the brainstem from the dorsal aspect and decussate before emerging. And the damage can occur at various locations, right from the nucleus to subarachnoid space to within the cavernous sinus or at the orbit. So superior oblique palsy is the most common cyclovertical palsy encountered by strabismologists. So the two forms are congenital and acquired. Around 3/4 of the cases are congenital superior oblique palsy. The etiology could be structural anomalies of the tendon, neurological anomalies, and clinically in these cases we mostly see a very large vertical fusional amplitude and facial asymmetry. So there's a contralateral facial macrosomia, which is a hallmark of a long-standing congenital SOP. Coming to the acquired cases of superior oblique palsy, so the causes could be trauma, microvascular, ischemic, neoplastic, iatrogenic, and inflammatory and infective. So the key clinical features of superior oblique palsy, starting from the clinical signs, there's a hypertropia of the affected eye with excitortorsion, a compensatory head tilt if carefully looked for. It is the most common presenting sign, present in about 85% of the patients. Typically, the head posture would be towards the unaffected shoulder. Some rare cases might have a paradoxical head tilt towards the affected side to maximize the image separation. A typical chin down AHP might be seen in cases of bilateral acquired superior oblique palsy to compensate for the induced V pattern in down gaze. The facial asymmetry, as discussed, often seen in congenital cases, is due to a long-standing head tilt, leading to midfacial hyperplasia on the side of the tilt. This was first noticed and documented by Parks. It's a very strong evidence that torticollis dates back to infancy, and it helps to avoid unnecessary neurological workup in cases of SOP. Some of the symptoms could be an annoying diplopia, vertical or torsional, especially in the acquired cases, typically worse when looking down while reading or walking downstairs. Eye strain, headache, difficulty focusing, dizziness, all of these as a result of effort to maintain fusion and avoid the persisting diplopia. The typical motility defects: underaction of the superior oblique, overaction of the antagonist inferior oblique, contralateral SO overaction, ipsilateral SR overaction due to contraction. A thing about the underaction of superior oblique, it might be seen only in marked neurogenic paresis or with very lax SO tendons. So it might be clinically less common than an ipsilateral IO overaction and is not always required to diagnose a superior oblique palsy. So the steps towards a diagnostic workup, the first is most essential is a good history taking, particularly the onset timing, any history of trauma, any previous surgery, family history of strabismus, any compensatory head posture position noticed by the parents in the child since childhood. Motor examination, of course, a cover test, a prism bar cover test, versions inductions testing, a Park-Bryczowski 3-step test, and hair screen analysis could be done. Sensory evaluation in the form of work node test, stereoacuity, suppression testing, torsion assessment with double Maddox rod or fundus photography, and imaging in some cases wherever it may be required. Now, about the Park-Bryczowski 3-step test, it is said to be about 70 to 75% sensitive for a unilateral superior oblique palsy. So the first step goes like, we need to look for which eye is higher in the primary position in the straight gaze. The step 2 is about looking for the hypertropia in the right gaze or the left gaze and noting down in which gaze the hypertropia is becoming worse. And the third step, also known as the Bryczowski head tilt test, tells us about whether the hypertropia is worse on the right head tilt or the left head tilt. So if the right, on tilting the head to the right, for example, forces the right eye to intort. So the right eye intorters the superiors, thus right superior oblique and the right superior rectus should work together to intort the right eye. In the case of a superior oblique palsy, when the right superior oblique is not depressing, the right superior rectus will overact unopposed as an elevator, causing the right eye to move further upward and cause increase in hypertropia in that particular tilt. Torsion is another very essential test that should be done in the case of superior oblique palsy. So there are objective and subjective methods for looking for the torsion. So double Maddox rod and Lancaster red green test are the subjective tests. Fundus photography and optical coherence tomography could be used for the objective assessment for torsion. So double Maddox rod is the most common clinical test that we can use for assessing the torsion. So torsion assessment often is called as the fourth step to complement the standard 3-step test. Helps to differentiate between a unilateral and a bilateral SOP. A unilateral SOP would typically have a less than 10 degree excitotorsion, and a bilateral one would have a large degree, typically more than 10 degree. Also can help to distinguish between congenital and acquired as an adjunctive. Acquired palsy subjective torsion is usually measurable and a prominent complaint. Congenital, it is often minimal or absent due to long-term sensory adaptation. Although objective torsion, we can still record by means of indirect ophthalmoscopy or a fundus photography. Torsion also very importantly helps us to distinguish SO palsy from skew deviations. So in SO palsy, the hypertropic eye is obviously extorted, whereas in skew deviation, it is often intorted or conjugate torsion is present. A very important point is if a spread of comitance occurs in a case of superior oblique palsy, the findings might be different from what we expect in a usual case in the form of torsion. We might not always find excitotorsion in the affected eye if it's a long-standing case when muscle sequelae have developed and there's a spread of comitance. So a brief of difference between congenital and acquired superior oblique palsy. So in congenital superior oblique palsy, diplopia of course is often absent and a head posture will be long-standing. In cases it will be a facial asymmetry. Tendon anatomy abnormality will be present in about 87% of the cases. A large vertical fusional amplitude and the muscle atrophy would be more prominent. Now, role of imaging in superior oblique palsy, the common imaging techniques, if required, are a high resolution dynamic orbital MRI could be done, a functional MRI or a CT scan. So the findings that could be there are of an SO muscle atrophy or a normal SO with abnormal pulleys, contractility issues, which can be elicited by a dynamic MRI, or the trochlear nerve in congenital cases, the nerve itself might be absent or hypoplastic. Imaging is not always required in all cases. In some cases, it might be used to confirm the diagnosis. So it's an objective confirmation of the clinical findings, especially when the diagnosis is uncertain, as 30% imaging confirmed SOP cases may have a negative Park 3-step test. In some cases, it may help to identify the cause, so it can differentiate neurological palsy from mechanical causes like pulley issues. And in some cases, it might help to guide the surgery by providing anatomical details which can help in surgical planning. A brief about bilateral superior oblique palsy. Mostly after closed head trauma, this can develop. There might be a subjective complaint of torsion. Objective torsion might be exceeding more than 10 degrees. A lot of cases have a minimal primary position deviation, although there's neither alternating hypertropia on head tilt, a prominent V pattern esotropia, and a chin down head posture. A very important and often missed and overlooked entity is a masked bilateral superior oblique palsy. So signs of superior oblique palsy appear in the normal eye of a patient after strabismus surgery for a unilateral SOP in the contralateral eye, despite the absence of signs of bilaterally before surgery. This palsy may develop in the previously unaffected eye and might be present in 5% of cases undergoing surgery for superior oblique palsy. NAPS has given a very useful classification, classified into 7 classes as per the gaze position or position of greatest vertical alignment, and this can be very handy in the surgical planning. A few of the differential diagnoses could be skew deviations, thyroid-related ophthalmopathy, Brown syndrome, and primary inferior oblique overaction. A suggested protocol for management of superior oblique palsy. So we can start with the Guyton's exaggerated tendon test. So on the tendon test, if we find the tendon to be esotendon to be normal or in acquired cases, we go on to look for the inferior oblique overaction. If the inferior oblique overaction is present and hypertropia is less than 15 degrees, we can weaken the IO in the form of IO recession or IO anteriorization. If the hypertropia is less than more than 15 degree, then we go on to look for SR restriction. If there is an SR restriction, then we recess the SR along with weakening of the inferior oblique. If there is no SR restriction, we can weaken the inferior oblique and recess the contralateral IO. This is in cases which have a normal SO tendon on the traction testing. In cases which have a markedly lax SO tendon proven on traction testing, we need to tuck the SO along with weakening the IO. And of course, in cases which have very, very lax SO tendon or absent SO tendon, we can weaken the absent SO tendon basically, we weaken the IO and recess the SR. In cases of bilateral superior oblique palsy, in the acquired cases with proven torsion, the Harada-Ito procedure is preferred. Coming to a few cases, this case was a left congenital superior oblique palsy with exotropia. To be noted, the exotropia was more for near than distance. So the horizontal deviation was 20 PD XT for distance and 24 PD for near. And the L by R was maximum in extroversion with a positive 3-step test. So this patient was managed by OSLR recession and MR resection and OSI recession 8 mm. So to be noted, around 50% cases of superior oblique palsy may have associated horizontal deviation. So horizontal near distance disparity is an important measurement even in vertical deviations, as horizontal deviation of 8 PD or more needs horizontal muscle surgery in addition to the vertical muscle surgery in case of superior oblique palsy. This is the same patient at 1 year follow-up. He has maintained ortho and primary and OS over elevation and reduction has resolved. So we need to target the maximum horizontal deviation, which was near deviation in this case, for which we need to do the horizontal and vertical deviation neutralization in all 9 diagnostic positions of gaze, both for near and distance. The second case was a case of bilateral congenital superior oblique palsy. Part 3 step showed alternate hypertropia and reversal of tilt on Bilchowski's head tilt test. Bilateral SO underaction, bilateral IO overaction grade 4, significant V pattern, and bilateral fundus extortion grade 4. This patient underwent bilateral anterior and nasal transpositioning of inferior oblique. So the over elevation and adduction reduced in both eyes and the V pattern also reduced. The same patient at 1 year follow-up. Bilateral congenital SOP, though rare, the incidence is around 5%. So at 2 years follow-up, the same patient is ortho in primary position with no over elevation and adduction. So anterior nasal transposition of inferior oblique is a very useful procedure in these cases where the IO is transposed anterior and nasal to the IR insertion, which converts the IO from extorted and elevated and adduction to intorted and anti-elevated and adduction. The third case is a case of left congenital superior oblique palsy with IO overaction grade 3 with a large angle alternate XT. So the horizontal deviation was 70 PD XT along with the typical features of superior oblique palsy in the left eye. So this patient underwent supramaximal horizontal muscle surgery along with the IO recession for the superior oblique palsy. At 1 year follow-up, the patient's ortho and the over elevation and adduction due to the IO overaction has resolved. So supramaximal surgery for horizontal recti can be combined with oblique muscle surgery in cases of superior oblique palsy. This third case was a case of bilateral masked congenital superior oblique palsy with XT. So there was an apparent eye overaction in the left eye, and right eye overaction was unveiled only on utilization of horizontal deviation. She had an alternate hypertropia and reversal on head tilt. Bilateral SOP confirmed on bilateral fundus extortion, which was significant. This patient underwent surgery in the right eye for the horizontal deviation, a right eye IO recession 8 mm, and left eye anterior transposition of IO. At 1 year follow-up, the bilateral IO overaction has resolved. So preoperative diagnosis of bilateral SOP is important. Otherwise, post-operatively, signs of SOP start to appear in the apparently normal eye, which is also known as masked bilateral SOP, found in about 10% of apparently unilateral SOP, which if not found beforehand, it will require a second surgery for optimal outcome. This fifth case was a case of right congenital SOP with residual XT. The first surgery for this patient was done for horizontal deviation 35 years back. No previous records available, no photos available. Only one eye was operated. So vertical deviation was 15 PD XT, maximum in levo version, left eye overaction grade 4, and significant fundus extortion. Was managed by right eye anterior nasal transposition of IO along with horizontal muscle surgery. So at 6 months follow-up, the overhead elevation and adduction has resolved. So patients with SO palsy and exotropia in whom fusion requires both horizontal and vertical prism correction while we are measuring the deviation, they have a high likelihood of successful horizontal alignment after LR weakening when appropriately combined with the IO weakening surgery. The sixth case was a case of a large congenital superior oblique palsy. The angle was 35 PD R by L in primary position. This patient was managed by a single muscle surgery, right anterior nasal transpositioning of inferior oblique. At 1 month follow-up, the patient has ortho and eye overaction has resolved. So a large angle SOP is defined as vertical deviation of more than 25 PD. So ANTIO was done in this, which is a very useful procedure for large angle SOP, SOP with DVD, missing SO10 tendons, and recurrent SOP. A few drawbacks of anterior nasal transposition like anti-elevation syndrome or fullness of lower lip could be there. Anti-elevation syndrome can be prevented by bunching together the anterior and posterior fibers of inferior oblique while it's reinserting, and avoid reinsertion of IO anterior to insertion of IO. The seventh case was a case of bilateral congenital SOP with esotropia. Typical features of superior oblique palsy were there, managed by OD right anterior nasal transpositioning of IO and left anterior transpositioning of IO, and at 3 months post-op as no over elevation and reduction. This eighth case is a case of left congenital superior oblique palsy with DVD with infantile residual ET, once operated 18 years back with high hyperopia. So her maximum vertical deviation in the extroversion was 35 PD with a significant V pattern and typical features of superior oblique palsy. FDT for the left SR was negative, FGT for bilateral MR was positive. Exaggerated FDT for SO showed some laxity of grade 2. MRI orbit was unremarkable, ASOCT unremarkable. Slit lamp examination gave us evidence of both the medial rectors being operated. So this patient was planned for a left anterior nasal transpositioning of inferior oblique for the SOP and bilateral lateral rectus resection. So on table, when we had taken up the patient for the right eye, we couldn't find the right LR muscle there. So basically, this patient was then managed by right LR advancement and resection because it was a slit lateral rectus and a left LR resection and left anterior nasal transpositioning of inferior oblique. The same patient at 2 years follow-up. So suboptimal outcome might be there if the features of congenital superior oblique palsy are missed out and a vertical deviation due to the SO palsy is not corrected and only a horizontal deviation is corrected like it was done in this case in the previous surgery done elsewhere. So to conclude, superior oblique palsy is the most common cause of isolated cranial nerve palsy and periodic vertical strabismus. Treatment is no doubt complex and challenging and surgical in most cases. Measurement in all 9 diagnostic positions of gaze and both for distance and ear are required, very essential to formulate the appropriate surgical plan. Most common surgical procedure performed is an IO weakening. Single muscle surgery may give great results even in large vertical deviations in primary position. Coexisting horizontal deviation needs to be tackled in the same setting for an optimal outcome. Binocular vision therapy helps to maintain long-term post-operative outcomes. Thank you.
Thank you, Dr. Bhavna, for excellent talk. Any questions to her?
I think it was very exhaustive presentation and topic is also very exhaustive and since we know superior oblique for almost 150 years and a lot of water has flown, a lot of things have happened, a lot of things are still being understood. And you separated congenital from acquired probably for understanding purposes. It will be probably better for the students because there are different presentations, different patient complaints and issues. And of course, you rightly said that some of these cases can present with an EXO or ESO about 90% may present with exo and about 10% may present with eso. Those who present with an horizontal deviation. So it is important to keep that in mind. And of course, when you have an exo or eso, there is a primary pre-oblique overaction. So you have to do a tilt test and see if there is a vertical coming. Because you can also have a symmetrical bilateral superior oblique palsy. So those things have to be kept in mind. Thank you, Bhavna.
I would also just like to announce for the PGs the release of this book on squint and orthotics called Theory and Practice of Squint and Orthotics. Primarily, the author has been late Dr. A.K. Khurana, and I've been the co-author of this book. So it will be a very useful book for the postgraduates. It's a very good combination of theory and the practical aspects of managing strabismus.
What is the cost? Because these people don't like buying books, they go to net and find almost everything on the net. Am I wrong? Younger ones particularly, they don't want to spend money on books anymore. क्यों भाई? कितना है पैसा? 1,000. No, that is no money, just a pizza.
Thank you, Dr. Bhavna. Now I invite Professor Reena Gupta. She will be speaking on Duane's retraction syndrome.
छोटा करना थोड़ा already one.
So it is 16 minutes. It's a very elaborate topic.
I know it's very complex
Yes.
and it's very large.
That is, so we'll do that for you.
It was too late.
So good afternoon. Thank you, Darren sir, for inviting me here. So we are going to talk about Duane's retraction syndrome. To understand the management, it's very important to understand what is the etiopathogenesis, what is the presentation of Duane's, and what are the various variations which we see in Duane's cases. So back to the history, it was described as early as 1879 by Luke. It was illustrated by Stilling and Turk. That is why we often refer to it as Stilling-Turk syndrome. In 1905, Alexander Duane, he published a case series of 54 cases, and the most essential finding was the globe retraction. So Duane syndrome has a spectrum of variations, but the commonly seen features are: first is significant limitation, or there is absence of abduction. As you see in this child, in the left eye, there is a -4 abduction limitation. There is globe retraction, or the narrowing of the palpebral fissure on adduction. So here we can see again in the right eye, there is an enophthalmos, which is known as globe retraction, and the height of the vertical palpebral aperture is reduced. Overshoots on attempted adduction, like in this patient, in the left eye, you see there's a typical upshoot on adduction. Patients can also present with abnormal head posture. There is a variable limitation of adduction, and strabismus is commonly seen, and chances of amblyopia are also high. Duane's are seen in 1 to 5% of the cases. It's very commonly seen in females, and the hypothesis that was given by Robert and Parsa was that during embryogenesis, there is increase in the inflammation, and also the estrogen levels are very high. And this predisposes the female fetus to venous thromboembolic events, which causes a dysregulated apoptosis, and hence these misinnervation anomalies. It's also very commonly seen in the left eye. I'm sure most of you must be seeing left eye is more commonly involved in the Duane's patient, and that is very common for the unilateral cases. And Duane's either seen as an isolated finding, or it can be seen along with other syndromes. Bilateral cases, they represent around 15 to 20%. Coming to the etiopathogenesis, this is a spectrum of mechanical causes. There are anatomical causes, genetic, as well as innervational disorders. Because of all this, now it has been categorized under the congenital cranial dysinnervation disorders. So mechanical is the shortening and the contracted lateral rectus muscle, which is the culprit muscle. Anatomical, you can see there's fibrosis or hypoplasia of the muscles, or sometimes when you're exploring a Duane's muscle, you come across the anomalous insertions or the bifid insertion of the lateral rectus also. 90% of the patients are sporadic, and 10% are familial. So the isolated patients, they usually have a DURS1 gene, which is located on the chromosome T2q31. And for the autosomal dominant variant, a lot of work is now being done on the CHN1 gene, which is seen to be mutated in the Duane's cases.
Central nervous system anomalies, most of the MRI scans have shown that in the DRS there is a hypoplastic abducent nucleus with absent sixth nerve. So deficient innervation of the lateral rectus muscle is substituted by the anomalous innervation by the oculomotor nerve. What is anomalous innervation? So if you see this diagram, you can see that the lateral rectus muscle is supplied by a branch which is coming from the third nerve. So anomalous muscle innervation is that which is received from a cranial nerve that does not normally supply that specific muscle. So for rest of the presentation, you will keep hearing the word anomalous innervation. That is coming from the third nerve. Electromyographic studies, they were started by Brennan in 1956, and these studies have shown the absence of the electric potential in the lateral rectus muscle on abduction and presence of the action potentials on adduction. They've also demonstrated that the different degrees of anomalous innervation which the lateral rectus muscle is receiving during adduction. And also remember that there is a range from no activity to subnormal activity to near normal activity of the lateral rectus innervation, the normal innervation I'm talking about, which it is getting from the sixth nerve. The paradoxical innervation of the lateral rectus is seen not only from the medial rectus but also from the vertical muscles. So this diagram here explains the anomalous innervation which is received by the lateral rectus. If you see the first picture, so here we can see that the medial rectus is giving the anomalous innervation to the lateral rectus on adduction. Now in the second, it is getting also from the elevation from the superior rectus. In the third picture, you see it is getting from the inferior rectus, and here the fourth diagram shows that it is getting from all the three muscles. Now the diagram E here represents that in addition to the anomalous innervation, the lateral rectus is also getting near normal innervation. So Huber classified Duane's retraction syndrome into three main types, and this classification was mainly based on those electromyographic findings and also on the presence of what is the type of deviation in the primary position. So when we talk about the type 1 Duane's, that is normally known as esoduanes. In esoduanes, you can see there is esotropia which is present in the primary position. And in esoduanes, the patient does not have the normal LR innervation. That is why there is an abduction deficit. And the adduction is almost full. Then we come to type 2, that is the exodiaris. Exo because it has exotropia in the primary position. And here, if you see, the abduction is almost normal because the patient is getting a normal activity from the LR innervation from the sixth nerve. But in addition to that, there is a lot of anomalous innervation which is going on in adduction, and that causes the adduction deficit. Why is it so? Because when the medial rectus is giving part of its innervation to the lateral rectus, there will be some deficiency of the adduction movement of the medial rectus. That is what happens in type 2 Duane's. Then is the type 3 Duane's. In type 3 Duane's, it can be ortho, it can be eso or exo. Now that will depend upon these imbalance of the mechanical and the innervational forces which is going on. So here if you see the child has abduction limitation also, along with that there is adduction limitation. So here we understood in type 3, the normal innervation from the sixth nerve is not there, but the anomalous innervation from the medial rectus is quite high and severe. So these are responsible for the various clinical features which you see in Duane's. So whenever you see a case of Duane's, you have to get a cyclorefraction test done. Why? Because these are prone to high hyperopic refractive errors, and that is cause of anisometropic amblyopia, which you see in Duane's cases. Then always look at the fixation pattern. Is the patient fixing from the normal eye? But sometimes what happens, normal eye might be having amblyopia, because of which the patient fixes from the Duane's eye. The moment the patient fixes from the Duane's eye, the degree of deviation is going to change, and that is going to change your management options as well. Sensory evaluation is must. Most of the Duane's cases, they have good sensory status because they are able to maintain their fusion with small head posture. Because a very typical finding of Duane syndrome is that the amount of deviation is very less as compared to the abduction deficit. So most of these patients will have a small face done and they are able to achieve fusion. Then we go the features of the anomalous innervation. So what are the anomalous innervation equivalents? One is globe retraction. Why is the globe retraction there? Anyone? Why do you see globe retraction in Duane syndrome? Because of the co-contraction of the medial rectus and the lateral rectus. So narrowing of the palpebral fissure is not a very specific finding. You should always look for globe retraction. And how can you see that? You can just retract the two lids, look for enophthalmos if it is present from below also. You can see a very visible enophthalmos and then you can grade it accordingly. Upshoots and downshoots. Now what is the cause of upshoots and downshoots? There are two causes. Mechanical as well as innervation. Mechanical is because of the tight leash effect of the lateral rectus muscle. So lateral rectus is holding the globe so tightly that the globe slips over. Okay, so it can go in the up direction, it can go in the down direction. And to elicit that upshoot or the downshoot, basically you always have to ask the patient to look little above the horizontal level. You cannot appreciate it at the horizontal level, so it has to be elevated. That has to be elevated up. So if you see a mechanical upshoot, that's usually very sudden in onset. Whereas if you talk about the innervational upshoot, now what is innervation upshoot? It is because of inferior oblique overaction or SR contracture. These are the secondary changes which come in advance. So whenever you're seeing an innervational upshoot, it's usually gradual to see, and moreover, there will be a hypertropia which is present in the primary position. So when you see this category of patients, you know this is an innervational upshoot. This has to be handled in a different way. So your management options are going to change. And upshoots and downshoots can be graded accordingly. So if you have a patient who has a very severe anomalous co-contraction, in those patients you can have even grade 4 of the upshoots where you cannot see the cornea, just goes hidden behind the lid. And we also call it as a pumpkin seed sign. Forceps test, we know, everyone knows about the forced duction test and the forced generation test. Duction test is important here because you know this is a restrictive type of strabismus in which you're going to have some tightness of the lateral rectus muscle as it is a shortened muscle. Apart from that, you have secondary changes in the form of MR contractures, SR contractures. You should do a forced duction test, look for those contractures. And then forced generation. Forced generation is going to tell you what is the active innervation of the lateral rectus muscle, the abducting force which the lateral rectus has. A very typical test of Duane syndrome, this was innovation done by Romero Apis in which they found a degeneration test. Now this test has to be done. What is it? You basically ask the patient to look somewhere midway between the primary position and the adducted position. Now once the patient has done that, you use a forceps and do a forced movement more towards the adduction. The moment you do move the eye towards adduction, what will happen? Co-contraction will happen, and then you can feel that resistance is coming because now LR is also trying to pull it. Okay, so at that time, if you ask the patient, look outwards, the co-contraction will go and you will realize that there's a relief of that tension which you can feel. So this test basically tells you how to get the anomalous innervation. You can appreciate that. So coming to the management with that background, very important thing in Duane syndrome is patient selection. You have to know when to operate and when not to operate. Okay, so because you know these patients are coming to you with good fusional potential, they are able to maintain their vision, the deviation is not severe, just let them be there, observe them, because the secondary changes might come with time, and then you need to go and intervene, of course. But there's a right time to intervene these patients. Surgery remains the mainstay of treatment. When do we operate? If we see that there is a significant deviation in the primary position, there is marked anomalous head posture, there are very severe features of the anomalous innervation like globe retraction, upshoots, downshoots, they are really disfiguring for the patient at times. Yes, you have to operate them. So this was the first patient. This was an 11-year-old female who presented with the left eye. She had an isometropic amblyopia, very high refractive error, plus 5.5 was there. If you see, the child has a -4 abduction limitation in the left eye. Adduction seems normal. There's a large ET of 50 to 60% diopters in the primary position. So, and there is no globe retraction. In this patient, what we did a bilateral MRI session, and you can see the patient was ortho in the post-operative period. A second case, a similar case, patient again, a 16-year-old patient who has abduction limitation, esodr's, but along with the large angle of deviation, this patient also has a globe retraction and an upshoot. So you have to identify that. So in such patients, when you have a esodr's with globe retraction and upshoot, what do? We plan an asymmetric MRI session along with the Y split of the lateral rectus muscle because that's going to correct your upshoots. And this was the result. Post-operatively, the upshoot was resolved and the globe retraction was significantly reduced. This was another patient. Had a left esodr's in which this patient again there was no globe retraction, just esotropia in the primary position. So we did a superior rectus transposition procedure. There was an MR contracture, that is why MR recession was added. So in esotrans, remember that these are the patients who are going to have esotropia in the primary position. Important thing to note is that they do not have a normal LR innervation, so there is an abduction deficit. Adduction is almost normal. There can be globe retraction and upshoots and downshoots might be associated. So in these patients, what is going to be a management strategy? First do FDT, see if there's a MR contracture or not. If there is MR contracture, you need to do a MR recession. If the patient does not have a globe retraction, no anomalous innervation, we can go ahead with the transposition procedure. It can be superior rectus transposition or it can be a VRT procedure. If the patient has anomalous innervation, look for the angle. If the angle is small, a unilateral MR recession is enough. But what is typical of MR recession in esodialis? Anyone? We do it more in the normal eye. Okay, so you touch the normal eye in these patients. Why is it so? Because this gives you a fixation duress and that helps you to correct large amount of esotropia, and in that particular case you're not going to get a overcorrection, which we people are always scary of, that if we operate on the Duane side, a large recession, you might come across a overcorrection later on. So if there is added globe retraction or upshoot, you can do it with the help of a bisplit that can be added to the asymmetric MR recession. Stephen Kraft has also recently said that LR resection can also be added to MR. Previously, you must have read in the books, it's written that LR resection is contraindicated in Duane syndrome. But now we are doing small LR resections, especially in cases where you do not see globe retraction. You can add up to 4 mm of LR resection can be added. This is another patient, a 4-year-old patient who had an exodeviation. So if you see, she has a good visual potential. Left face turn is there for distance and near. In both eyes, there was an abduction deficit and adduction deficit both. Both eyes have severe globe retraction and severe upshoots. Very large angle of exotropia at the primary position. A vertical squint is also there. So how was this patient managed? A bilateral exodialis patient with severe globe retraction with upshoots was managed by doing a bilateral supramaximal LR recession with bisplit. You can see the follow-up results early and late post-op period. The head posture is resolved, the globe retraction and the upshoots have been corrected. But yes, there's not much improvement in the abduction. This was a residual hypertropia which was led, for which inferior oblique surgery was planned in the second stage. A similar case of right exotropia, again same. You can see very severe upshoot in this patient with a small angle of deviation of around 16% diopters. So in this patient, a unilateral LR recession with bisplit was planned. These are the post-operative results of the patient. You can see the patient's alignment was quite stable and the globe retraction upshoots were treated. So another patient in which there was a very severe globe retraction and upshoot, in this patient along with the bisplit LR recession, MR recession was also added. So when we talk about the exotropic Duane, what you need to remember is that in this patient, you are going to have limited adduction because of the anomalous innervation. The abduction will be nearly normal and there will be features of anomalous innervation. So how do you plan the treatment? In these patients, again, you look for what is the angle of deviation. If it's less than 20, go ahead with a single LR recession. If you are having larger angles, you can plan a bilateral LR recession. Again, depending upon the anomalous innervation, if there are upshoots and downshoots, add a bisplit. Bisplit is a very useful procedure. You get good results with it. And if it's a very severe globe retraction, what you can do, you can eliminate the culprit LR muscle. How are you going to eliminate it? Do a periosteal fixation. Do a periosteal fixation and do a partial VRT, and you get good results with that. A word about the bisplit procedure. This procedure was advocated by Jampolsky. What you need to know here is that on the insertion, you go back posteriorly as possible. You're splitting the muscle into two halves. You see the upper half has been placed 10 millimeters above the insertion, lower half 10 millimeters below the insertion. So you need to have a distance of 20 millimeters between these two halves. Because what will this do? This will remove the influence of the lateral rectus from the crest of the globe. And that is the point where the slippage occurs. So this really treats the upshoots and the downshoots. So this is almost my second last slide. So another thing which you see is a straight Duanes, which is known as ortho. Okay, ortho in primary position. These are the patients who are. It's very difficult to decide for these patients because they come with an immobile globe. So they have both abduction and adduction deficit. So these are the patients which you are going to go for, not to operate. Okay, if they have a good fusional potential, you can just follow these patients. But if you see that the fusion potential is not good or they have disfiguring upshoots and downshoots, then you can plan a surgery, but with a good counseling to the patient, that maybe two-stage surgery might be needed. So take home message is that in DWANS, the surgery is the mainstay of treatment, but of course, with proper counseling and patient selection is must. You need to know that you can treat the ocular deviation in the primary position, you can improve the upshoots and the downshoots, but the duction movement is not improved much. With transposition procedures, we are able to improve some duction deficit, but not completely. And again, a tailored case-based approach is required for treating these patients. Thank you. It's more of a teamwork with the parents and the patients.
Thank you, Dr. Reena, for an excellent talk. Any questions to Dr. Reena?
I hope it was quite clear.
It was quite exhaustive and it's a very broad topic. That's what I was telling you in the beginning only, that only thing I just wanted to say something about exo-DRS. Exo-DRS is not that there is no abduction limitation. What is happening is that the LR is undergoing fibrosis and contracture. So some ESO-DRS can also pass on to exo-DRS. So that is important to keep in mind. Other thing is the medial rectus in ESO-DRS is not contracted.
So later on, if it comes in long-standing cases,
No, it doesn't get contracted because there is always the adduction is not usually slightly subnormal in these cases. It's not as good as in a normal ESO deviation. So that has to be kept in mind. Of course, bilateral DRS have to be looked differently because there are different cup of tea and you have to be very careful. You have to be careful about indications, as you rightly said, because if you operate for wrong indication, you'll be punished. Thank you.
Thank you.
Thank you, Dr. Reena. Now I invite Professor P.K. Pandey sir. He will be speaking on DVD.
Thank you, Dr. Subhash, for the invitation. This place is like coming home for me because I spent half of my life here. I joined in 85 and retired in 2020. And this building didn't exist when I joined. That ward block had just begun in 86. Otherwise, we were admitting patients in LNJP before that. So the entire thing has changed massively, and of course, a lot of ophthalmology has gone under as well. So everything has changed. So I'll be talking about dissociation rather association. Normally, we like to talk about association, convergence, and symmetry. I'll be talking more of how to bring out association out of dissociation. So these dissociated deviations have always been a bit of problem in understanding because we tend to think of deviations as concomitant, and beyond concomitant we get into a bit of flux and we don't know what is happening. So what are dissociated and non-dissociated deviations? If you look at them, the dissociated deviations are change in vergence brought about solely by change in the balance of visual inputs between two eyes. That is, it's a open loop. It's monocular, means there is no feedback. When we talk about non-dissociated deviations, change in vergence brought about by fixation reflex, sensory and motor fusion. So this is a closed loop mechanism. This is a binocular. So we have to understand that we began with a monoocular visual system. I don't mean human beings, way down in phylogeny. So from monocular lateral-eyed animals, we got into binocularity because we came out from ocean to the terrestrial and arboreal life. So that had its own issues, and we got into this business of binocularity, and the strabismus came in. Otherwise, there was no strabismus as long as we were lateral-eyed. So cortical binocular single vision of primates means stereopsis, depth perception, and limited field of vision. Cortical monocular vision of lateral-eyed animals means primitive reflexes, panoramic field of vision, no stereopsis, and fusion. So a DVD is basically a writing reflex which has gone wrong. It was required in lateral-eyed animals for balance and for verticality. But as we got binocular, these reflexes got suppressed, and we got into this business of whenever. So the point is that whenever there is breakdown in binocularity or binocularity has not developed, you may have a DVD along with things like primary inferior oblique overaction, latent nystagmus, and smooth pursuit asymmetry. So this is dorsal light reflex in fish and insects as well, that the eye which is having less light if the animal is tilted, so accordingly, this eye which is having less light tends to elevate and balance the animal. So this is part of a basic reflex which was there. And when we get into poor binocularity, this reflex comes into play. It's like an atavistic phenomena that we had it lower down and we get into this atavistic response. Then we have to look at DVD and oculotilt reaction. So this DVD is a raw plane disorder. Raw plane means like this, like this. This is raw. If you look at the plane, how it is, it goes into three planes: roll, pitch, and yaw. Pitch is if you are going up and down, that is pitch. Roll is if you press one flap, plane goes this way. Put this flap, it goes this way. Press both flaps, it will go up. The accelerant will go down. So that is pitch. Then the yaw. Yaw is basically that there is sideways movement, left and right. So DVD is a raw plane disorder as compared to primary inferior oblique overreaction, which is a pitch plane disorder, and latent nystagmus, which is a yaw plane disorder. So you have to understand these three planes of motility. Same way, oculotilt reaction is also a raw plane disorder. And how we are having OTR? OTR is basically coming from where? OTR is coming from the vestibules, the utricle, the saccule, and the semicircular canals, because these are balance organs, and eyes and utricles, the vestibules work together to keep us in balance, because if we are not having good balance, we will fall down and somebody is going to eat us up. So verticality is very important. Sun from above and gravity from below. They are the two major determinants of any life on this planet, be it plants or be it man or beast. So in DVD, you can say DVD is an inverse OTR. DVD is driven by imbalance of visual inputs from the two eyes, and OTR is driven by the imbalance of autoretic inputs from the two eyes. DVD, only problem is DVD is hypertrophic eye is distorted, whereas in OTR, the hypertrophic eye is intorted. So that's one difference, and other eye will hypertrophic eye will be extorted. Now, DVD has been an enigmatic condition. A lot of nomenclature has been going on since like I think 1895, when Stevens called it anaphoria, whatever, anatropia. And it was Belshowski who in 1938 coined the term dissociated vertical deviation. That was the first time, and then we started understanding it better. Belshowski was a Jew, and when Hitler came in, he had to flee to United States, and he was given a clinic and he worked there. And 1936 he migrated, and 1940 he died in a New York hospital. So only 4 years he had there. Belshowski also worked with Hoffman and Hering at Leipzig University. You have that Hoffman-Belshowski head tilt test to begin with. In 1900, he described that with Hoffman, and later on in 1938, he refined it for superior oblique palsies. So DVDs, as we say, they are driven by unequal visual inputs to the two eyes. Non-fixing eye, as you know, will elevate and extort and abduct, and the fixing eye will intort and depress. The horizontal component can be ESO or EXO. Quite often it is EXO, but you can also have an ESO DHD. Very rare, but can happen. There is also a torsional component, which is known as torsional dissociated deviation, and may also dampen. DVD is also known to dampen latent nystagmus. I'll be showing a video where we did surgery for the DVD, and you find the LN has got worse. Just showing a video. So if you look at this, now this is a case of infantile exo, and he has, see, you can see the DVD very well. You can also see the LN, and his vision is poor in the left eye as compared to the right eye. So you see more DVD in the left eye, and he was a twin born. We'll be talking about this case later also. The second twin, 500 grams, and the other twin who was normal The first twin, he did not have infantile deviation, he had an exo deviation, and this fellow had infantile deviation. So what I was saying that these blend into each other, the infantile and exo and phorias. Next. This was we had operated infantile esotropia, and you can still see the residual DVD, a very small amount. What I'm saying, the infantile esos, even if you have operated infantile deviations, so you may have a small DVD in these cases. So it is usually DVD comes by 1 year, but even if you have operated infantile deviations, DVD may come in later and may need surgery. So, so presentation can be इसको फिर कर दो slide mode में ना तो बड़ा आ जाएगा हाँ
Present a view of the key record share gameplay of
So you can see it.
तो वो तो क्या था slide show हाँ आ गया so चलो छोड़ दो next we go next so so presentation can be broad and it's known as marker of infantile early onset deviations. We say that this is failure of binocularity. So whenever there is a non-development or acquisition of binocularity or failure, you may have a DVD. Not that all of them will have. Age of presentation is young, usually around 1 year, but it can come later also. Maybe asymptomatic symptoms may be cosmetic, or maybe some cases may complain of diplopia initially, but as time passes, they will have suppression and not have diplopia. Most cases are asymmetric, bilateral, and rarely strictly unilateral. So whenever you have DVD, always think of it as a bilateral condition. It may be very asymmetrical, so you need to be careful about that. Like superior oblique palsy, as Dr. Bhavna was talking, you have to be careful about bilaterality. This could be tropic or phoric, as we said. Hypertrophic hypertropia is variable, may increase with inattention, and at different points of time, you may have different amount of DVD. So one reading may not always be very precise. So you need to look at them a couple of times, like intermittent exotropias also, things can be variable. Competence is what we say that there is a difference in the deviation in the DVD in adduction and abduction. So difference of 7 prism diopters or more is taken as incompetence. This is important because this is going to determine what surgical procedure you are going to do. There could be associated abnormal torsion and pattern strabismus. Now, one thing important is that the torsion DVD, the eye is extorting as it is going up. That is not the baseline extortion. Like superior oblique palsy, you have baseline extortion, but in DVD, eye extorts as it goes up. So the torsion, basic torsion could be normal torsion, extorsion, or intorsion. Only when the eye is going up, it is going to extort. So there is also rarely you also have a hypotropic DVD. Some cases have been described. I have not seen one, but there are reports you will find in literature that this has also been described. Now, unilateral DVDs, as I said, it is bilaterally symmetrical, usually asymmetrical, but you have a lot of sensory deviations in our country. A lot of patients who have had cataract surgery, had trauma, been operated, left aphakic, and they end up with a sensory deviation. And I've seen they are very worried about it. I've seen them being more worried than people who are having concomitant deviations because very worried about the cosmesis. So these sensory deviations, which are usually exo deviations, ESO ones, I don't see too many. So they say that below 5 years they go for ESO and over 5 they go for exo. But 90% I have seen these are exo deviations. And some of these will also have a DVD. They can also in free oblique overaction, they can also free oblique overaction, and also once in a while a DVD. So the problem here is that if you do cyclovertical surgery, it will create a hypotropia. So these are difficult cases to manage, and if you do horizontal as well as vertical, you may also induce ASI. So it is a very tight situation. What should be done in these cases? So what we do here that you do horizontal recti recession and LR recession and bring the insertion down by about 3/4 tendon width. That I've seen corrects this DVD in these sensory cases very well. We'll be showing some cases, 2 cases in this. Now DVD about 1/3 can have an HP as well. Head tilted towards the fixing intorted eye. Opposite is also this can be to control DVD to establish peripheral fusion. Head tilt towards the fixing intorted eye. That is the hyper eye. To the superior oblique palsy, you have head tilt towards the other side, the hypo eye. So this at times you can also have superior oblique with DVDs, as we were talking. So it needs to be seen that you can have a head tilt in DVD as well and superior oblique palsy. So that needs to be seen. Now what we need to do in these cases, important to distinguish a non-dissociated, that is primary inferior oblique overaction, primary superior oblique overaction, and dissociated DVD and DHD components, because that's another thing important, that if you don't look at DHD, then you will miss that component and this can affect your results and outcomes. So classically we do prism under covers. I'm not going into that detail. The reverse fixation test we do for DHD, which is very important because after doing PVCT, you do reverse fixation test, then you know how much component was which was concomitant and how much component is DHD. So it's important to keep that in mind. Deviation in 9 gauge we need to see, or incompetence. And as I said, incompetence for more than 7 PD is important. You can classify them into small, till about 9 prism diopters, 9 to 19 as moderate, and more than 20 as large DVD. Those which are more than 15 prism diopters are usually a bit difficult to manage as compared to smaller ones. There could be associated esotropia, exo, latent nystagmus, SPA, and poor binocularity in these cases, as we all know. This is reverse fixation. Now, management, non-surgical management can be basically you have to encourage fusion, that is by prescribing glasses, switching fixation, or even correcting horizontal deviation. If there is an associated exo or ESO, once you correct that, the DVD may get better or it may turn phoric, so the problem may be solved a bit. Now, surgical challenge in DVD is open loop disorder, as we said, imprecise measurements, variability, variable dose response relationship, if it is unilateral, bilateral, asymmetry, incompetence, coexisting motility disorders like DHD and LN, and if there is abnormal torsion or pattern, because these will determine your response. Like if you have a V pattern and you are doing large SR recessions already, so it will produce a V pattern. So you need to probably transfer these insertions nasally, nasal transposition, so that you will not have so much of V. Now, not all DVD needs to be put under the knife, as Dr. Reema was saying in UANs. You have to be careful which ones you are going to treat. And there are no uniform indications. Increasing frequency of manifest deviation, ASP to control DVD, large DVD occurring frequently may be broadly the reasons. And unilateral surgery has to be, you should avoid, because once you operate on one eye, the other eye is going to show DVD. So if you are not sure that this is strictly unilateral, which will only be if there is poor vision in that eye, so don't go for unilateral surgery in these cases. So surgical options are many. Small SR recession with FADEM was done earlier, but now I don't think most people are doing FADEM in DVD. Large SR recessions are the standard procedure. Large, by large we mean that more than 6 to about 12 or 14, but 6 to 10 most of the times we end up doing 6 to 10 or 12. IR sections are not done as primary procedure; they are done only when SR recessions have failed. IO, SO weakening procedures depending upon the incompetence. Weakening both elevators if the DVD is large. And inferior transmission of logical recti as we have done in the sensory deviations with DVD or a combination of these procedures. So in competent, we can do SR resistance of about 7 to 10 per millimeters, depending upon how much is the DVD and how much is the asymmetry. Small SR resistance we don't do with Farden. The earlier reports are there, but it doesn't have any advantage over large resistance. Weakening both elevators, if there's a large one, you can weaken inferior oblique as well and the SR. And ATIO, because ATIO can also give rise to anti-elevation syndrome in the other eye. So this may also work in those cases which have some inferior oblique overreaction. Small error SR resections and IR resections are not recommended. There were some reports earlier, but no, it's not. I think. Now, incompetent DVD greater in abduction, IO recession, ATIO and ANTIO, depending upon how much is the primary inferior oblique overreaction. And this you showing inferior oblique decision depending upon where you want to place it. And this is ATIO, you all know, and this is ANTIO. These procedures are well known, all of us are doing as and when, but you should be aware about the indications and the issues. Like ANTIO is also going to induce intorsion and it is going to act as depressing force. So that part has to be kept in mind. Now, if there is incompetent DVD more in abduction and then PTSO with SR recessions will need to be done, they will also have an A pattern which needs to be taken care of. So for that, you might have to do PTSO on the SRs. These are some cases. These are from Guru Nanak only because we didn't have videos. So this was an infantile EXO, as you can see, large EXO and DVD, which we did by SR recessions. This is showing intorsion in this case. Normally, you find that normal torsion, but what I'm saying that they can have intorsion or extorsion or normal torsion. So that is possible very much in DVD. This was with ptosis. As you know, ptosis can give rise to poor vision. Probably the DVD part was because of poor vision in this eye. So you can have all these possibilities. This was again DVD with DST. In infantile XT, you see large deviation. So you have to measure the PBCT part, which is concomitant, and also DHD by reverse fixation test. This we did large decisions, bilateral and feels good. SR decision with SO weakening in this case. And then we have unilateral DVD with sensory exotropias, as we were talking that these you can't switch fixation and more than 2 recti you cannot operate in one sitting because that will give rise to esotropia or it will need multiple procedures. So they want in one surgery, they want everything to be treated and they're quite desperate. So what we do here, this is one patient, you can see poor vision in the left eye because of anisometropia and amblyopia. And this is showing 9-gauge motility, no inferior oblique overaction, little bit of V pattern, and this is showing extorsion in this case. Now this extorsion doesn't reflect through the inferior oblique overaction. So some of these cases which have gone for breakdown of fusion, they may show torsional changes. So probably in this case, the extorsion which you see in the left eye is because there has been no fusion for quite some time. So the eye has ended up with more extorsion. This we infrapress the LR about 3/4 tendon width down, and after that you can see the DVD part and exo part has recovered a great deal. We also did MR resection. This is showing motility after that, and the extorsion part has got slightly worse, I think, because we have placed the inferior rectus inferiorly, so that could be there, but that doesn't really matter. They have very poor vision. Then we were talking about this child that we saw earlier. It's a preterm twin, 7-month-old with birth weight of 500 grams. The other twin had intermittent exotropia, and I operated on both of these recently. Now this is, you can see the motility. This video we have seen. I think I need not go back. Shall we? उतने वो तैयार नहीं इसको रोक दो. So, so we had in that video what I saw showed you that there was a DVD and there was less LN. Now when we see the video after the surgery, now you find that DVD part we also did infra placement in this case also. What is happening is you will see that DVD is not there, but LN has increased. Now look at the LN in this eye, this also. So once DVD is gone, what they say that DVD is trying to control the LN, the torsional component and the horizontal component. So that probably needs to be studied. This video very well shows that the DVD is corrected, but LN has got worse. So as far as vision is concerned, the movement has become more. So vision may actually drop. So yeah. So surgical growth only DVD is only elevated, rarely eliminated. Recurrences under corrections are common. Secondary preoblique overreaction, pattern strabismus, large SR recessions should be done. Induced hypertropia if you do in one eye, and torsion changes can be there. There could be deficiency of upgaze if you have done large SR recessions, and there could be anti-elevation syndrome. There could also be lid fissure changes because if you have done large recessions or if you have done IR resections, they can also produce lid fissure changes. So it's important to do on both the eyes, rather do surgery on one eye. So to conclude, supranuclear disorder treated at infranuclear level, presentation diverse, surgical treatment challenging, frequently seen with infantile sensory deviations and other deviations rarely. It may only be elevated, rarely eliminated because it is a supranuclear problem. We can't do that. And inferior transposition of horizontal recti needs further study to tackle these DVDs which are happening concurrently with the horizontal deviations. Thank you.
Thank you, sir, for an excellent talk. So basically, the only cosmetically disfiguring DVDs should be treated first. Second, usually it is bilateral problem, so we have to treat. If we have to treat, we have to treat in both eyes. And thirdly, there is no consensus regarding the universal procedure for DVD, but large SR recessions are the procedure of choice.
Scientists, I have one question. Sir, how much DVD this procedure should it inferior transposition of the radial
About 10-15% of it. If it is more than that, it will not correct. I forgot to say that. About 10 to 15.
The small DVD that
हाँ, उससे बहुत बड़े वाले इसमें होते भी नहीं usually, but it should not be very large. We are saying less DVD now. I don't know over years. When I was young, Bhavna might remember. I think we saw more DVD.
Definitely.
Now why it is going less and less? Maybe we have less infantile deviations.
Maybe lesser of.
But with prematurity and low birth weight, infantile deviation should be going up. So it is a complex matter. I think if you take out statistics, maybe we'll have some window into that.
I think the large deviations are less of DVD, but we are seeing subtle DVDs now, which are coming like with the nystagmus is there, small DVDs there, but not like the unilateral DVDs which we used to see. That has decreased.
No, I think DVD as such, I am seeing less. So I think Bhavna might agree. पहले वाले जो ज़्यादा होते थे, उसके reasons क्या हैं? Like exotropia, we see more exos now. One reason could be myopia. So a lot of things there. You know, it's very interesting actually, and we need to look back how things are changing over years. Dr. Subhash needs no introduction. Dr. Subhash, please.
So maybe the cause is that a lot of squid surgeons you have produced over a period of time, they are seeing in the periphery and they are not coming to you now.
No, it's not that. I think whatever we get, these cases are complex, so most people don't tend to operate these. They tend to refer them. These ones with DVD and all that. So usually they like to touch the horizontals and leave out these cyclovertical issues. So that's different. And there's some very aggressive surgeons. That's a different matter. Yeah.
So, very good afternoon to one and all. I will take only few minutes. So basically, this monocular elevation deficiency is very close to my heart because in 1998, on this topic, I presented at American Academy of Ophthalmology. So basically, it is defined as inability to elevate parietic eye from any position of gaze, provided ductions are normal in all other positions of gaze. It may be congenital or acquired, parietic or restrictive or supranuclear. These are various photographs. So causes could be congenital, SR paresis, inferior rectus restriction, and acquired may be serious disease, mid-brain tumors, and in our setting, cysticercosis is a common cause. So this is photograph of one of the patients in which cysticercosis was cause of MVT. Type 1, in which there is IR restriction is prominent feature. Type 2, elevated weakness is prominent feature, and type 3 is the supranuclear type. So what are the clinical features? There is limitation of elevation above midline, both abduction and adduction. There is hypotropia of involved eye. There is presence of ptosis and pseudotosis. Chin elevation is there, usually unilateral. Marcus gun jaw winking phenomena is seen in approximately 25% of the patients. So for diagnosis, it is very important to ask history of onset, and if sequence of event is not clear, then presence of myopia suggests congenital etiology. You might look for previous photographs. In acquired cases, you have to see history of neurological symptoms, past medical history, and general systemic symptoms. So basically, we have to differentiate between acquired and congenital MED, and in acquired MED, there is acute onset of diplopia in upgaze. Neurological symptoms are there. Ptosis is usually not present, and it may be associated with pupillary anomalies and convergence weakness. Bell's phenomena is usually present, and patient often assume a chin up head position. These are the differentiating features between congenital and acquired MED. Various differential diagnoses are Brown syndrome, vertical twins, congenital fibrosis of inferior rectus, congenital absence of SR-IO, abnormal insertion of IR and SR, and superior divisional thread palsy. These are other differential diagnoses. So, this is 20-year-old female resident of Delhi, which presented with chief complaint of diplopia since 1 month. These are the obesity and diplopia findings. So here Brown is ruled out because there is elevation deficit in adduction and abduction. So basically ultrasonography was done and cystic lesion within inferior rectus was seen. In this patient, you are seeing this cystic lesion. MRI was done, you are seeing the cystic lesion. Patient was given oral albendazole and steroids, and patient was orthophoric, and elevation limitation also got resolved. So basically, this was case of acquired MED which did not require surgical intervention. So this is 8-year-old girl with upward deviation of right eye since birth and abnormal head posture since 3 years of age. These are the examination findings. Right eye is extorted. This was case of congenital MED. Another patient, 32-year-old male, resident of Delhi, presented with chief complaint of drooping of eye and diplopia on upgaze since 2 months. Past record shows operated left eye or left SOP, underwent left eye recession 12 mm in 2012 and underwent SR recession in 2013. This is the clinical photograph. These are the examination findings. There was localized congestion present at the site of tendon insertion. So probably it is inflammatory pathology. This is the diplopia starting. Imaging was done, SR was thickened. CT and MRI were done. And HRCT shows hilar limb adenopathy, and on investigation there were high S levels. So diagnosis was acquired monocular elevation deficiency due to inflammatory pathology, query due to sarcoidosis. Patient was treated by the physicians. Another patient, 40-year-old male with left hypotropia and limitation in elevation from all positions of gaze. These are the MRI and brain and orbit findings, and this was case of fibrous dysplasia. Another case of left hypotropia with limitation of movement. These are the MRI findings, and this was case of snide wing meningioma. Another patient with 20-year-old female with post-traumatic MAD. FDT was suggestive of tight IR, and here the treatment of choice is IR recessive. So what are the indications for surgery? If there is presence of significant AHP in primary position, there is presence of significant vertical deviation in primary position, contacted binocular fields, diplopia in primary gaze. In most of the patients, you have to observe because with limited head changes, orthophoria may be maintained. But treatment for MAD is, for congenital MAD is surgical and only surgical. Goals of surgery are to achieve cosmetically acceptable deviation in primary position, to increase the field of binocular signal vision, and it is very important to tell to the patient that surgery will not cure the MAD and more than one surgery is required. And usually these patients, they present to you for ptosis surgery. So you have to tell the patient in very clear terms that first squint surgery has to be done, and after that only the ptosis surgery will be done. Various surgical procedures are according to the type. Type 1, recession of involved inferior rectus has to be done. In type 2, NEPS procedure is well established, commonly practiced, but drawback is patient loses some abduction and adduction, and effectivity decreases if deviation is more than 25 prism diopters. These are the NEPS procedure. Modified NEPS procedure in cases of patients where there is horizontal deviation which is associated with MAD. Vertical recession and resections can be done in selected patients. Esotenotomy and vertical recession have been found to be effective in congenital MAD by Chinese study. Sneer and et al. Recommends NEPS procedure with posterior fixation suture. Is 24-year-old male with right MAD. IR recession was done. Another patient, pre-op photograph of MAD. NEPS procedure was done. Post-operative photograph of the same patient. Another patient with traumatic MAD. This is post-operative photograph. Another patient, pre and post-operative photograph of the patients. Here we have done a thesis regarding this newly developed Nishida's procedure, modified Nishida's procedure, and these are the pre-operative and post-operative photograph after Nishida's procedure. This is another case of left MAD, post-op photograph of same patient. Right eye MAD, pre-operative photograph. This is post-operative photograph of same patient, excellent correction. So another question is whether you do inferior rectus recession, NEPS procedure, modified Nishida's procedure, or vertical recession and resections. When to intervene for ptosis? So you have to wait minimally for 6 months after squint surgery because magnitude for vertical correction increases with time following NEPS procedure. Thank you.
Thank you, Dr. Subhash, for a very nice presentation. I think you have very extensive experience in MAD. I think wonder if anybody else has more experience than you. Of course, I think one thing has to be important to say that you have to see how much is the IR contracture and how much is the SR function left. So that will determine how you are going to handle it. Of course, differential diagnosis is very well brought out. In some cases of pseudotosis, I had done surgery on the other SR just to create a fixation duress. I think maybe long term they don't work that well, but immediately for months or 1 year, have you done any case like that?
For immediate cosmetic purpose, that can be done.
Yes, it does work out initially. So
especially in young girls who are
those who have a lot of pseudotosis, that means when the eye comes in the primary position, ptosis almost disappears. So that is important to keep in mind how much is pseudotosis and how much is the actual ptosis. I think that's important. And really, you have markers done in these cases. There, yeah. Anything? Anybody wants to say something? You are feeling hungry or?
So, thank you everyone, and I will ask Dr. Reena to come for a memento.
Thank you, Dr. Subhash, for organizing a very wonderful CME. We all enjoyed it. It was all your efforts, and please continue with this activity. It is, I think, very useful to everybody, to PTs and all. And I also like to be here, being my old alma mater, not alma mater, but it's my home, you can say. Alma Peter will be more appropriate. There's nothing like Alma Peter, I think that's a new word. Thank you.
Dr. Bhavna.
Bhavna का Alma Peter है. Thank you so much, Bhavna, for coming. It's wonderful to be here.
इसको बंद कर देना ऑफिशियल
अनु को नहीं दे रहे हो?
नहीं सब हमारा अपने इंटरनल
In-house.
नहीं तो देना चाहिए भाई.
हमारे
This is discrimination.
That's the first